to our international rounds, and good morning to everyone. So it's my great pleasure to introduce Professor Markus Schwerzmann. I tried your name quite a lot, but I'm not sure where I'm going to get it very well. And Markus is the director of the ACSD unit in Bern, and he just recently has published a paper about, I think, what it is one of the most challenging topics and extremely important in our population is about advanced care planning in other congenital heart disease. So, Markus, the floor is yours, and thank you very much for joining us today.
Hello, and thank you very much for the opportunity to address this, let's say, timely topic, especially now during the Corona crisis. But I would like to focus still on adults with congenital heart disease, and the topic is advanced care planning. And the picture you see, this is a header of a Swiss broadcast called Sternstunde, and in English this means something like magic moments. And it was actually Corina, our nurse practitioner, who brought my attention to this emission. And she thought it would serve as an excellent introduction to the topic, because the topic of this broadcast was about death and the society's attitudes towards dying. And one of the speakers invited during this emission was a former funeral director who then studied psychology. And he was called an expert in the field of thanatology. And thanatology is the scientific study of death and losses. And in the Greek mythology, Thanatos was the personification of death. One of the statements of the interview with Martin Prine was his claim that most of us are intrinsically afraid of death, even if we claim not to be so. And he argues that this is simply evolutionary biology. Every species seeks its preservation, including humans, and despite all cultural progress, all medical advances, all steps away we have made in the past from behaving like animals, death continues to be a big fear and therefore an important taboo in our society. Sorry. And the next statement came from the head of the intensive care unit at the University Hospital Zurich, discussing aspects of dying during the Corona crisis in the intensive care unit. And he actually ended his interview with the following words: as doctors, we don't have just a task to keep patients alive. It's equally important to accompany them during the last moments of their life. And I guess with this introduction, the society's attitudes towards dying, our fear of death, our commitment as healthcare providers to deliver the best possible care for patients during all parts of their life, I guess I have set now the stage why it's urgently needed that we should address advanced care planning in our patients. Much of the content I'm going to discuss in the next minutes is actually a summary of a recent position paper of the European Society of Cardiology about ACP in ACHD patients. And this work was a collaboration of the ESC Working Group for ACHD, the Association of Cardiovascular Nursing and Allied Professions, the European Society for Palliative Care, and ISAC. And so you will find many familiar names among the co-authors, like Lorna or Adrian. Let's first discuss definitions. What is advanced care planning? It's actually a process or a concept, but a process that supports and empowers individuals at any stage of their life to consider, to communicate and document preferences for future healthcare to their loved ones and healthcare providers. And during this process, patients have the opportunity to make decisions in advance about treatments they would and would not want, should they be unable to express their wishes at that time. This process can end with the creation of certain documents, like advanced directives or physician orders for life-sustaining treatment, and the naming of a healthcare representative. This is an individual that a person entrusts to express their wishes and make medical decisions on their behalf, should they be unable to speak for themselves. I guess it's important to be aware that ACP and palliative care, that's not synonyms. I think palliative care is a medical subspecialty, and advanced care planning is a process that, of course, will also include aspects of palliative care and will need the palliative care team at the end of this process. Sorry. Another terminology I would like to address is advanced directives and POLST. Advanced directives are paper or electronic documents that specify a person's preferences, including beliefs, goals, and values, and decisions, like the naming of a healthcare representative, for medical treatments of care or care in advance of a potential serious medical event when they may be unable to communicate this information. It's not the first aim of an advanced directive to list all potential future health crises that may arise and may need specific medical attention. It's our current understanding that such advanced directives should enable healthcare providers to make medical decisions that are in line with personal values. So in other words, they should be able to make in-the-moment decisions congruent with the patient's presumable wishes. POLST, on the other hand, are binding medical orders that tell healthcare providers what they have to do in very specific situations, like no referral to the intensive care unit. But a POLST document does not include such general aspects like values or the naming of a healthcare representative. Let's go back to Switzerland. Actually, only in 2013, Switzerland introduced a new law on child and adult protection, providing now the legal base for advanced directives. And 5 years after the introduction of this law, a group of Swiss researchers interviewed more than 2,000 Swiss aged 55 and older about their attitude and knowledge regarding advanced directives. Nearly 80% of participants had already heard of advanced directives, and there was a high level of approval. However, only 24% had completed advanced directives. There were marked differences between the different parts of Switzerland with respect to awareness and completion, and you can see the lowest numbers were found in the French-speaking part. There were also differences with respect to the age of the patients. The older the resident, the more likely he or she had advanced directives. There were differences between men and women. Women were more likely to have advanced directives, and also the ones living with no partner were more likely to have advanced directives than the one living with a partner. What about the situation in ACHD patients? During their time in Toronto, Daniel and Matthias, in collaboration with Adrian and Jack, studied different aspects of ACP and ACHD. And I guess they were one of the first to really address this issue. And so in 2012, they published a paper in the International Journal of Cardiology about preferences of ACHD patients and their healthcare providers regarding end-of-life communication. You can see 200 patients and 48 healthcare providers completed the survey. Only 2 patients, 1%, indicated that they had discussed end-of-life planning with their medical team. In contrast, you have over half of all providers who report that they typically discuss issues including life expectancy and advanced care planning with the outpatients. The majority of patients agreed that they thought end-of-life issues are important and wanted the medical team to address these issues. And interestingly, independent of disease complexity. And 62% of all patients favored initiation early before facing life-threatening complications. On the other hand, healthcare providers, they preferentially address ACP in patients with complex lesions, and only 38% favored early initiation. So there was somehow a little bit a discrepancy between patient wishes and providers' attitude. So it was interesting to read a quite similar study, but now 8 years later. It's a paper from Jill Steiner as first author and Adrian as last author, and they published another survey on healthcare providers' perspective about ACP and palliative care. 50 healthcare providers, typically ACHD cardiologists in their 40s, attending physicians, working more than 50% of their time in ACHD and in academic center, responded that overall they had a low level of personal knowledge regarding palliative care, but they were aware about advanced directives and recognized them as important. Also, the percentage of healthcare providers who would initiate ACP ranged from only 20 to 67%, depending on the clinical situation. When the provider were asked about the best time to initiate ACP discussions with their patients, you can see that only 38% responded before patients get sick, while healthy, and in all patients, independent of disease complexity. 40% responded before patients get sick, while healthy, but only in patients with moderate or great complexity. And only 22% of providers reserve these kind of discussions to situations when patients were diagnosed with a life-threatening illness or with complications. So I guess still 8 years later, there is some work to do. Again, Jill Steiner, also this year, published a summary of 25 semi-structured interviews in ACHD patients, aged 20 to 63, 24% with a simple defect, 30% with a moderate defect, and 44% with a complex defect. And all patients expressed a desire for knowledge about their future health, but the responses to the ideal age when these kind of issues should be addressed differed quite substantially. You can see here some examples. Some patients said as adolescents, some said at the age of 18, 30s, 40s, 35. A 41-year-old male with complex disease regretted that this issue hasn't been addressed earlier. One said in the 50s, and only one patient said 65 and older, and interestingly, this was a woman with complex disease. In their conclusions, the author stated that patients supported routine incorporation of ACP in clinical practice, but the timing and form of this discussion must be individualized, using shared decision-making between clinicians, patients, and families. I would like to go back to this 40-year-old female with complex disease. I guess what is interesting to see is, or to look at, is how do patients see for themselves the life expectancy? And this has somehow implications, because if you think you're doing fine and you will happily for the next 40 years, you may less likely have thoughts about ACP, and you may less likely be wondering what your future will look like. But interestingly, patients with chronic conditions usually overestimate the life expectancy. This has been shown for patients with heart failure, COPD, and also for dialysis. This is a recent meta-analysis of different papers who published self-estimated life expectancy versus observed life expectancy. And the same observation can also be seen in ACHD patients. This is a study published in 2006 by Graham Reid as first author using the database of the Hospital for Sick Children in Toronto. These patients were part of a larger project on psychosocial issues and transfer to adult care. And among many other questions, patients were also asked, what do you think is the average life expectancy for your peers who do not have a congenital heart defect? And what do you think your life expectancy is? And you can see that for themselves, patients expressed a mean age of 75. And this mean age was almost as long as the mean age of the healthy peers. For them, they estimated 79 years, and this was quite in line with the statistical life expectancy in 2002 for Canadians. But 85% of patients estimated to live longer than the estimates by the medical team. And interestingly, life expectancy perceptions often related to risk factors for acquired heart disease. And they lacked awareness of CHD-specific risks. So I guess we really have unmet needs in ACHD patients when it comes to preparing them for future healthcare problems, including end-of-life questions. And this is why we set out to formulate the CSC recommendations, but in parallel, we tried to define a specific ACP concept for our institution here in Bern. And I just can say that this kind of work has to be teamwork. You need all members of your team to agree about the priority of ACP, and you need them to be willing to incorporate ACP in clinical practice. In our institution, much of the work and initiative was done by the nurse practitioner, but all doctors were willing to participate, gave the input in discussions and brainstormings, and in the end, we really had some kind of teamwork success. And now we're really able to implement ACP in daily life. If you want to implement ACP in your clinical practice, these are some of the critical structural requirements that should be met to make you able to deliver effective and successful ACP. First, you need a concept, you need a defined process, and you need to identify triggers when and in whom you should start these kind of discussions. Then, as I said, you need a team. It's difficult to do this as a one-man show. You need to clarify responsibilities within the team, and you need a liaison with the palliative care team. Then it's also important to have documentation and storage possibilities. You need to make sure that everybody of a team, but also the whole hospital, has access to advanced directives. At the same time, that these are protected according to legal requirements. As a doctor, we may also need some training in communication skills because we usually are not used to this kind of talks. And it's also helpful to have some possibilities of debriefing or coping structures, because these kind of discussions sometimes can be burdensome, and it's good to have the possibility to exchange your experience with others. If we agree about the importance of ACP, let's talk about the benefits of ACP in cardiovascular diseases. ACP has benefits for heart failure patients, patients with end-stage valvular heart disease, patients with arrhythmia, and most likely also patients with ACHD. In the ACHD population, this hasn't been investigated really so far, how much patients benefit from ACP. But this slide summarizes the benefits without referencing the specific literature. You can find this figure and the corresponding literature in the position paper, and actually this figure was drafted by Lorna. You can see that ACP benefits the individual. They spend less time in hospital, they are more likely to die in the preferred place, and they have some sense of relief and control, ending with an increased peace of mind. The family benefits from ACP. You have family congruence regarding care objectives. The family is more aware of the loved one's wishes. And once a patient has died, the family has also early access to bereavement services. For the healthcare system, you have a reduced length of stay, reduced readmission, reduced inappropriate care, and in the end, improved provider satisfaction. And for the society, you have reduced costs. It leads to discussions about quality versus quantity of life. In the end, also discussions about limitations of care, and it can reduce the fear of paternalistic medicine. So if we see the benefits of ACP, we agree that it's important. So why are we still behind patients' expectations when it comes to providing ACP? Because we have to overcome barriers on multiple levels. These are the barriers, some barriers on the patient level. I guess it's important that we provide education about the rationale for ACP. This may diminish the level of minimal knowledge. We have to introduce and normalize this topic in our clinics during routine visits and offer patients the opportunity to discuss ACP in more detail at a follow-up visit. We have to introduce ACP during stable phases, and we have to inform our patients about the advantages of ACP for family members, should they be faced making treatment decisions for the patients in the future. This may overcome the desire of the patient to protect family and loved ones. If he realizes the advantages that ACP can have for his family, for the ones left behind, then I think he will understand the importance of ACP. We have barriers on a healthcare provider level. And I think barriers are related to emotions. And we have to acknowledge that emotional reactions to disappointing information on patient side are understandable, they occur, and they do not indicate that the patient has lost the trust in the physician. In contrast, many patients will tell you that addressing these issues has strengthened the patient-physician bond. Of course, we are uncertain about the prognosis of our patients, but we can use broader time ranges for life expectancy, like decades or years. We can rely on published data, let's say the data from the Brompton about life expectancy in their patients. And I think we can try to make just the best estimate we are able to give. I think to overcome the lack of confidence and skills in ACP, well, we just have to seek for education opportunities. We have to train, we can use checklists, and I think we can use a standardized approach to initiate ACP discussions. On an institutional level, I think it's important that we clarify responsibilities. Who is the one responsible for initiating the ACP process? Is it the treating ACHD doctor, the nurse practitioner? Do we want the family doctor to address these issues? I think it's important that the responsibilities are clear. Of course, we have lack of times, but sometimes it's possible to schedule specific ACHD visits just addressing ACP. And sometimes it's also more easily to address this kind of issues in the inpatient setting. And the issue of reimbursement has to be addressed on an institutional individual level. What can be triggers for ACP and ACHD? As I told you initially, of course, this has to be individualized, but I think if we have a list of potential warning signs, we may be more ready to address ACP in our clinic. These are some disease-related triggers. If we are faced with a complex CHD patient with markedly reduced life expectancy, we maybe don't want until his 60s until we address this issue. If a patient has to undergo complex cardiac surgery with a mortality risk of 5%, I think it's wise to address ACP prior to surgery. In the setting of the diagnosis of advanced heart failure, prior to ICD implantation, or particularly if we address issues like heart transplant or ventricular assist device, I think it's mandatory that we talk about future healthcare preferences. There may be also a trigger coming from the patient side. Sometimes we really have patients who express their interest in future health discussions. Sometimes we are also confronted with patients who have completely unrealistic health expectations. I guess in this situation, it's our task to maybe offer them to talk about their future health. And sometimes we have patients who have just lost somebody close to them and they have an increased awareness of mortality. And this is also an opportunity to address ACP. And a last but general trigger is the surprise question. If I have a patient in front of me in my clinic and I ask myself the question, would I be surprised if this patient dies within the next year? And I say no, then I know that ACP should really be a topic for this patient. If we start ACP, we propose a staged approach. A staged approach means that we tailor the content of our talk and the actions to the anticipated life expectancy. If I have a patient in front of me with an anticipated life expectancy of decades, then maybe some general talk about future health expectations might be all that is needed. If life expectancy is more years than decades, then maybe addressing issues like advanced directives or the naming of a healthcare representative might be important. If life expectancy is in the range of months, then of course we have to address end-of-life preferences, and we need also, I guess, to liaise with the palliative care team. And in the last day of his life, I think then he needs end-of-life care, and end-of-life care is usually provided, at least in our setting, by the palliative care team. Let's go a little bit more into the detail of these stages. So what are the kind of patients that we see in stage 1? It's the ACHD patients who express themselves interest in ACP, or the patients with unrealistic health expectations. But we think also ACHD patients with a markedly reduced life expectancy, like a Fontan patient, or one with unrepaired cyanotic heart disease, or the ones with a systemic right ventricle. In these patients, at one point in time, we should address ACP. And the age in which we try to address these issues can be quite variable. But in our position paper, we proposed 40 years of age. Because in these patients, if a Fontan patient is 40 years of age, his life expectancy compared to the general British population is similar to the one of a 75-year-old inhabitant. For cyanotic heart disease, life expectancy at 40 is comparable to life expectancy in 70 in the general population, and for a systemic right ventricle with 40, life expectancy is comparable to a 60-year-old person from the general population. The ones in stage 2, life expectancy years, are the ones with advanced heart failure. If we address transplant assessment, if we discuss about ICDs, and I guess also the ones with risky procedures. The ones at stage 2 are the ones where we say no to surprise question, or the ones with end-stage heart failure. And stage 4, of course, this is the dying patient. And what do we address in these stages? As I said, if life expectancy is decades, then I think talk about future health expectations may be all is necessary. We can present the concept of ACP, and we can address issues about goals and personal values. And of course, at any stage, we should also offer to include relatives to the talks. In stage 2, we have to revisit the elements of stage 1, but now we really have, I think, to go into more detail of ACP discussions and address the issue of advanced directives, polls, and the naming of a healthcare representative. And in stage 3, we again have to revisit what has been discussed previously, but we also have to address end-of-life preferences, topics like device deactivation, the liaison with the palliative care team, and how we can support family members. And stage 4 for the dying patient, here really we have to provide end-of-life care, and once the patient has died, also bereavement care. One final word about communication skills. I guess some of us may need some training. I needed some training. And one concept that I read about was this ask, tell, ask principle. And I guess this is a good idea to make sure the patients understand what we want to express, and we can ensure that the patient has understand what I wanted to tell him. It starts that I ask patients what they know about their heart defect and what they would like to know. Then I tell them what I think is important information, what I want them to communicate, and then I ask them what they understood, and I ask them to tell them in their words what I just told them previously. And if you do so, you realize that what you say and what the patient understands must not necessarily be the same. But by this kind of structure, I think so far that's the best way I read about and I experienced so far, that we can optimize that the patient's understanding and our expressions are quite identical. This is another paper published in the JAMA in 2014 with some communication tips on how to break bad news. It has some do's and some don'ts. If we talk about future health, they say give a direct, honest prognosis. Don't respond to a patient's request for information about prognosis. Provide prognostic information as a range. Acknowledge uncertainty. Don't be just too vague and talk about incurable, but don't be overly specific and tell them, well, you have to live 6 months, no more. I think what's also important, allow for silence. Don't talk more than half the time. As I said, acknowledge and explore emotions, and don't just provide factual information in response to a patient's emotions. Don't just focus on medical procedures, but try also to address the patient's quality of life, his fears, his goals, and his concerns. I think it's important for the patient to understand that active disease treatment and ACP discussions are not exclusive. They coexist. It's always helpful for the patient and also for the loved ones to have informations about their current situation, and for the loved ones to know the patient's preferences and priorities. And over time, disease-targeted treatment may shift to more like palliative care measures. if symptoms increase and therapeutic options are more limited. And then I think it's important to be prepared for in the moment of decision making, and advanced directives, polls, and the naming of a healthcare representative might be supportive elements. But again, also on a care setting, active disease target treatment and palliative care again are not mutually exclusive. And so to summarize, I think ACP is a staged and repeating process and not just a one-time event. The notion of disease progression and specific triggers should raise awareness to mention and initiate ACP, of course, if wished by the patient. Within every stage, we should try to include the family members, but with any stage, we have also to reflect and clarify previously documented wishes. And a trusting relationship between the healthcare representative and the patient is facilitated for the initiation of such discussions. Well, let's go back to the intensive care specialist at the hospital in Zurich. I guess he was right. And like us, supporting patients to be well prepared for the final journey may also be for us one of the most challenging but also rewarding experiences. And with that, I would like to thank my team. It was a pleasure and a great experience to work on this position paper. I learned a lot. I'm very grateful for the support I received from them, but also for the work of Matthias and Daniel, who laid the base for this kind of future work. Of course, for the ESC working group on ACHD for all the support and collaboration, especially also Adrian for the input, and also Jack for his input. And of course, my thanks goes also out to many others. And with this, I would like to thank you for attention. Thank you.
Thank you, Markus, for excellent presentation. And the paper is now open for discussion. So if you want to ask any questions, either you can type them on the chat or open your microphones and just ask them. While people think about the questions, I have a question. So one of the most challenges that I find, apart from all the ones that you have said already, when to start, how to do it, how to address it, communication, etc., is when you want to do it, but the patient doesn't want to hear it. So that patient that you said, well, have the expectancies that they have for their lives is more than you know that is going to happen, and you try to address the topic, but the patient actually is not receptive. So how can we deal with that kind of patient?
I think it's, as you said, it's important that it's also wished by the patient. And if the patient is not receptive, then I think we simply cannot address it. But in my experience, I think if you address this topic, and even the patient's first reaction is a no, and I don't want to talk about it, it still works on him or on her. And maybe if you see him next time in the visit, or maybe he has a clinical event in the meantime, I think he will be more prepared to address these issues as if you never addressed it in the past. So I think it's important that it's a shared decision to address ACP, but it's also our importance to highlight the possibilities and the option of ACP. And I think many patients so far in whom we never have addressed the issue of ACPs, these are the ones who are simply unaware of this option. So I think we cannot force them to talk about it, but we just can raise awareness for ACP, and I think that's what we should do.
I agree. Any questions? Erwin?
Thank you very much, Markus, for this outstanding and very inspiring talk. And actually, ACP has become a very hot topic. I traveled the journey of ACP I think 20, 25 years ago, this was not the topic at all. And I grew up in rural areas, and ACP was not the topic at all, because dying or death was among us, because we were living with that, even as children. But in our modern society has a big change, and our modern society is struggling to accept the process of dying and death. That's in 2020. But so in 2010 or 2011, or when Matthias and Daniel were here, we had 2 or 3 suboptimal experience with patients, or end-of-life experience, and this triggered then all this discussion of their research. And I remember in 2012 at the Toronto Symposium in Toronto, we put a plenary session on advanced care planning, and also a breakout session. And many individuals, even key individuals in the ACG community, told me, Erwin, what do you want to speak about? I think this may not be a very interesting session, may not attract a lot of people. What happened? The opposite was the case. This was the most popular session, and the conference room was fully packed. There was a lot of discussion, and from there, so to the last 8 years, I think we have made some major progress. I think each ACG physician is aware of the importance of this topic, that we should address ACP action in a timely manner. And personally, I think we are still doing a suboptimal job when we are seeing this patient. There's still room for improvement. I think this ESC position paper is a beautiful paper to give us directions how to address this topic. Thank you, Markus, and the ESC Working Group on Adult Congenital Heart Disease for publishing such a nice position paper.
Thank you very much. I think you see it quite similar as me. I think nowadays the awareness for ACP has risen, and we all know about ACP. But I think the next step that we should now address is to implement ACP in clinical practice. I think there are still many clinics out there who don't have actually a real ACP concept. Of course, we can talk about ACP and say we do it, but I think we need to do it in a structure method. And I think the structure for delivering ACP is still missing in many clinics. And I think this is the next step to address that. We agree that we should provide ACP, but now we have to think about how we can actually do it.
So look, just joining that comment, Lorna has a question, and she said that did you find any surprises, good or bad, when you try to implement this environment?
I must say it was only a positive surprise. Initially, it was also from my side quite reluctance to address this issue, and I felt insecure on how to approach patients, how to start this kind of discussions. But I guess the more you do it, the more you feel comfortable. And what I really realized is that it really strengthens the bond between patients and physicians. Initially, I thought I might frighten my patients. They will never want to see me again because I address this kind of issues. But in all patients I addressed ACP, as a feedback, I received some kind of relief because they always had it in their mind, but they never dared to express it to their physicians, but also to the family. And at the same time, the family knew that the patient wasn't doing well, but the family didn't also not dare to address this kind of health issue to the patient. So everybody was realizing that something is not going right, but nobody wanted to address it. And it really brought some kind of relief if you actually speak out what's going on. And the second thing is really that if you address this kind of issue to a patient, and it's a very personal topic, and it really, the patient is grateful for you, and it's an expression of confidence that you can have these kind of discussions. So the really positive thing I can take from implementing ACP in our practice is that I just received positive feedback. So far, I didn't have any negative experience. There are, of course, patients who don't want to talk about ACP, but this we have to respect. But in the ones who are willing to enter this topic, the feedback I received so far was just positive.
And did you do it in the normal clinic, or do you have a specific clinic to do it?
I usually address this issue once in a normal clinic, just to say, did you already think about your future health? Do you have any expectations? What are your goals? And if the patient wants to address this topic, then usually we book him for a second appointment. We really have, I think, 30 or 45 minutes time just to talk about his understanding of the disease and his perception and his goals. So I can't do it in a normal clinical visit. In the clinical visit, I just express the notion of ACP, but I have to see him once again in a specific clinic to go into more details.
Any other questions? Lorna has comments here. So are there cultural issues addressing this? Any cultural issues? So I noticed that the difference between French and German and Swiss in terms of being aware of the ACP and this kind of discussions.
Yeah, I think there are cultural issues. There are also religious aspect that you may have to consider. But I think what's important is that you have, once a patient you want to address this issue, I think you have to prepare yourself for this kind of talk. You can't just come into the clinic and sit down and to be not prepared. I think you have to know a little bit about the patient's background, and you can also, maybe if you want to, if you know his religious background, I think you can try and respect what you think is appropriate. But of course, I'm not an expert in all kinds of religions, but I try just to address what I know about the patient, and I try to formulate my words in a sense that it doesn't hurt the patient. What we know from the studies is that actually in all religion beliefs, ACP is a concept that is accepted. There's not one religion who says it's wrong to talk about future health care. So the concept of ACP is a concept that is actually in line with all religious beliefs.
I have another question here by Barbara Wicher, which was one of our former fellows. It's in Austria now, and she said, "Thank you for the great talk. Did you also start ACP and life expectancy discussion in women who come for pre-conception counseling, so before becoming pregnant?"
Yes, I think you have also to address it. Maybe the question you have to address is what is the understanding of the woman of that defect, and what are their future health expectations? And if these expectations are in line with what you think will be her estimate for the future, I think then you don't have to go into much more detail. But if you see that the woman has really quite unrealistic health expectations, then maybe it's time also at pre-pregnancy counseling to inform her in more detail about the defect and its prognosis.
Any other questions from the floor? Okay, so I think that Candy say thank you for the great talk. I think it's a topic that where I find we have to learn a lot. I think that it's a topic that we talk a lot about it, but after we are not very good implementing it and bring it up to our patients. I think that's one of the points that you made, and I think this position paper is being great and a massive advance for the specialty. I hope that make us to change our practice and address these issues, which I think are key and important. It's something that I've been very interested in. I don't have a clinic apart to do it, but it's something that I really discuss with my patients. But I recognize I myself have to improve, and I think all of us have to improve. So if there is no more questions, Erwin, I think you want to say something. I can tell.
I think that bioethics is very important when you have to make decisions in patients who are asking us for inappropriate treatment. This happens if the patients do have unrealistic expectations, and we have to address this very challenging issue. And then if a patient asking us for inappropriate treatment, for instance dialysis, which is inappropriate anymore, do we have a close cooperation or have a representative from bioethics in your team?
No, but we have been faced in the past with these kind of topics when patients wanted treatments that just didn't make sense on a medical base. And these kind of discussions we discussed with the palliative care team, and at least here in Switzerland, it's really that it's not what the patient wants to have that you have to provide, it's what you as a doctor think is reasonable. And in case you are confronted with a patient who wants to have done everything, even if he's dying, at least in our institution, you can deny this wish. You have to explain him why you deny it, but you don't have to follow his orders. So this is at least the situation here in Switzerland. I don't know if this differs in other countries, but that's what we have discussed with the palliative care team.
I think this is a little bit different here in North America, so I have to learn it. So when I was in Switzerland, as you just said, we as physicians made the decision whether or not this patient has DNR or CPR. And usually we didn't even discuss it with the patient. This was 20 years ago, but I'm sure this has changed in Switzerland now. But here in North America, we have to discuss CPR on every patient who is admitted to the hospital and documented in the electronic chart. And we need to have this discussion, or should have this discussion with every patient, even if the 90-year-old patient who is admitted for anything. But in Switzerland, when 20 years ago, when an 80-year-old patient or 90-year-old was admitted, we as physicians made the decision. But has this changed now in Switzerland, this approach? Probably it has.
It hasn't changed in the sense that you can still make your decision, what you think is appropriate. But what is important is that you have to communicate your decision to the patient. And the patient has, of course, the liberty to say, well, in case you don't treat me like I want to be treated, then I look for a different hospital. But it's not that the patient can force you to make a treatment that you think is not appropriate. But you have to communicate it to the patient.
So I guess it's getting close to 9 and we have to close down, but I want to make a comment. I think there was one of your slides that I think summarized very well why we don't do this well, is the comment that the intensivist made, is that I think we are trained as doctors to cure patients and see this kind of approach as against of what we've been trained for. I think we do forget that as doctors, we have an obligation, of course, to treat patients and cure them. But there's a moment that we are also responsible to say, well, from here, my role is just to help you to have absolutely the best death that you can have, because there is nothing I can do to prolong your life. And I think we diminish that part of our profession, which I think is as rewarding as the other one if you do it properly with tools like advanced care planning and properly discuss with the patient. I think that is what we have to change, and as doctors in our minds, to be able to be comfortable with these kind of discussions. That's what I think. Okay, Markus, so if there are no more questions, there is a lot of thank yous and great talks in the chat. So Candice say hello, and I can see her waving there. So thank you for the amazing talk, and thank you for joining us today. Thank you for actually putting this paper together, which I hope that change our practice in the future. And thank you all for joining us, and see you here next week. And good morning, good afternoon, or good night, wherever you are in the world. Thank you, Markus, and see you around.
Thank you. Bye-bye.
Hopefully see you soon after COVID. Hopefully see you soon.
Yeah.
Okay.
Bye-bye.
Bye-bye.